Hello, I'm Paul Shealy. I'm a board-certified surgeon. We practice in Savannah, Georgia at Coastal Empire Veterinary Surgery. The purpose of this video is to familiarize small animal veterinary practitioners with the techniques of performing intra-articular injections. Lameness in companion animals is typically evaluated by a comprehensive past, pertinent, and current medical history, including a review of response to any medications, a thorough physical exam, and gait evaluation. Further musculoskeletal and neurological examination should help exclude neurological cases that may mimic orthopedic causes. Joint disease is typically evident by more intense lameness, periarticular enlargement, effusion, loss of range of motion, and pain, laxity, and crepitus on joint manipulation. With the carpal joint, while flexing the joint, palpate the distal radius, the proximal carpal bones, and the distal carpal bones. Flexion achieves maximum open space, and the most common joint evaluated is the radiocarpal joint, located in the cranial depression between the distal aspect of the radius and the proximal row of the carpal bones. Insert the needle from the cranial surface to one side of the central common digital extensor tendon and avoiding the accessory cephalic vein. It is uncommon to access the distal joints. However, these joints communicate, and only one insertion site is necessary. In smaller patients, a 25 gauge needle may be helpful in entering the carpal joints. Even though polyglycan SA is viscous, patient slow, even plunging of the syringe allows administration through the bore of the small needle. For the carpus, your landmarks are the distal end of the radius, the proximal row of carpal bones, and with flexion and extension there's a palpable depression that indicates the radiocarpal joint space. You angle your needle into that depression and slowly insert. This joint is shallow, so you don't have to go very far. For joint injection, simply remove the barrel of the syringe and your pre-placed needle, attach your loaded syringe, and slowly inject. Once the injection is completed, release the pressure off the plunger, slowly remove your needle. Flex the elbow moderately, opening up the joint space between the humerus and the ulna. Aim the needle medially and introducing the needle just lateral to the triceps tendon. You want to direct the needle just proximal and parallel to the olecranon and advance between the lateral condyle and the aconial process in a downward and cranial direction. A longer needle, 1 to 1.5 inches of 23 gauge, may be helpful in large or giant breed dogs. And once we've identified the olecranon, we would like to position a needle just lateral to the triceps tendon, and we want to angle it somewhat medially so that it goes in between the medial side of the lateral epicondyle of the humerus and just to the lateral aspect of the aconial process. Shoulder joint. Palpate the distal spine and the acromion process of the scapula and the greater tubercle of the humerus. Flex the joint space to widen it out. It may be helpful for an assistant to hold the limb level and apply slight traction to further open the joint space. From a lateral approach, direct the needle perpendicular to the skin, just cranial and distal to the acromion process, proximal to the lateral aspect of the greater tubercle of the humerus, and lateral to the supraglenoid tubercle of the scapula. Angle the needle slightly downward in a caudal medial direction while advancing into the joint. Your landmarks is the acromion process of the scapula, the greater tubercle of the humerus, and the supraglenoid tubercle of the scapula. You want to pass the needle just proximal to the lateral aspect of the greater tubercle of the humerus, lateral to the supraglenoid tubercle, and distal to the acromion. Slowly insert your needle into the joint. For injection into the joint, simply remove the barrel of the syringe and reattach the loaded syringe and slowly inject. Once your injection is complete, release pressure off the plunger and remove your needle slowly. Tarsal joint. Fully flex the joint and palpate the small gap between the medial aspect of the lateral malleolus of the fibula and the distal tibia. Position the needle parallel to the calcaneus. Insert in a slightly medial direction. The joint is shallow, so the needle does not require advancement very far. Another approach is from the cranial and lateral aspect. Slightly flex the joint and palpate the cranial space between the tibia and tibial tarsal bone. Direct the needle in a medial direction, and again, this joint is shallow, so you don't need very much penetration. To approach the hock joint, we go laterally. There are 2 points of entrance, caudal and cranial. Your landmarks are the lateral malleolus of the fibula, the calcaneus, and if you press your thumb in, you can feel the distal end of the tibia. By flexing and extending the joint, there's a depression that you can feel with your thumb, and that's your port of entrance for your caudal injection site. We like to angle the needle cranially and distally and medially. Feel your depression and go between the lateral malleolus and the distal end of the tibia into the joint. The joint is very shallow, so you don't have to penetrate very far. For the cranial insertion site, again, you can flex and extend the hock, and there will be a smaller depression that you can palpate with your thumb, and with a little less flexion of the joint, angle slightly upward and medially into the cranial aspect of the joint. And you don't have to go very far again because this joint is very shallow. For injections of the joint, simply remove the barrel of syringe with a pre-placed needle, attach your loaded syringe, and slowly instill into the joint. Once you're through injecting, release pressure off the plunger and slowly remove your needle. Partially flex the joint and palpate the distal patella and the proximal tibial tuberosity. Position the needle in the center of the patella tendon at a point slightly proximal to the midpoint between the patella and tibial tuberosity. To assist avoiding the fat pad, angle the needle slightly upward and advance, guiding the needle toward the endocondylar notch. The stifle, We present it in somewhat of a flexed position, and you would like to be able to palpate the patella as well as the tibial tuberosity or crest. And where we insert our needle is about just above midway up the patella tendon, between the patella and the tibial crest. And I like angling in a little bit of an upward direction to go past and over the top of the fat pad to facilitate either fluid draw or putting in polyglycan. Most people have always gone on either side of the patella tendon. I feel like that it makes it much easier to go straight in. So you place your needle in contact with the skin and just put gentle force and pressure as if you were angling up toward the endochondral notch of the femur. And once you get in, let go and do a gentle aspirate. And sometimes you get fluid right off the bat, and sometimes it helps if your assistant flexes the knee and you put pressure on the joint capsule itself with your other hand, and that might often allow more fluid to be obtained. And don't be surprised if even in an affected stifle like this that you may not get an abundance of fluid, but what you get can be utilized either to make a slide, to do cytology, or if you're enough to have a quantity sufficient enough to put in an EDTA tube to have the fluid analyzed as well. Hip joint. An assistant is helpful in manipulating the limb. In a lateral approach, palpate the greater trochanter. Slightly abduct and outwardly rotate the femur. Traction of the limb may assist opening of the joint. The needle is positioned immediately proximal to the greater trochanter and inserted in a slightly distal and ventral direction. For the lateral approach to the hip joint, your landmarks would be the greater trochanter of the femur, and for point of reference, the tuber ischii and the wing of the ilium. We distract the hip joint just a bit and externally rotate. And you want to go just proximal and slightly cranial to the greater trochanter at an angle, and slowly insert your needle. To inject product into the hip joint with your pre-placed needle, remove the syringe and replace it with a loaded syringe with your product and slowly inject. Once you're done with injection, release pressure off the plunger and slowly remove your needle. A ventral approach to the joint is accomplished by palpating the pectineal muscle and by abducting and adducting the femur, simultaneously palpating the femoral head. With the index finger of one hand, depress the skin caudal to the pectineal muscle, applying firm pressure to contact the femoral head. Then guide the needle adjacent to and parallel the finger in contact with the femoral head. Direct the needle into the joint cranial or caudal to the femoral head. If you palpate the pectineal muscle and just go directly cranial and of it and depress your finger in, and if you abduct and adduct the limb, you can palpate the femoral head moving. You take your needle and you go parallel to your finger in a downward direction into the hip joint. For injection into the hip, with your pre-placed needle in place, we remove the syringe and attach the loaded syringe onto the pre-placed needle and do your injection. Once you've done with injection, release pressure off the plunger and remove your needle. Microinvasive arthroscopy for diagnostic and therapeutic joint procedures is available for use in companion animals. The 1.2 millimeter needle view arthroscope by BioVision is a breakthrough in technology, providing practitioners more potential expansion into joint therapy with a compact and portable all-digital arthroscopic suite. The benefits of immediate enhanced visualization allows for clear evidence of joint penetration as well as pathology and direct interarticular treatment with obvious benefits over staged radiographic, ultrasonographic, or advanced imaging modalities. The needle view rigid scope with the directional view is 50% smaller than standard arthroscopes, incorporating both a high-resolution, lightweight 480 line digital camera and digital LCD medical-grade monitor and a xenon light source for superior illumination and color visualization. The system includes a full video and still imaging capturing system and is compatible with Windows 2000 or XP practice management software.